Lara literally wrote the book on everything from PCOS, PMS, and endometriosis to perimenopause and everything in between. So we're in really good hands tonight with Lara. And then Hannah, the lovely Hannah Boyd, is obviously the founder of New Leaf, and many of you will already know Hannah. She spent the last 11 years changing people's lives through her hugely successful naturopathic practice, focusing in particular on mental health, hormone health, and fertility. And outside her time seeing clients, Hannah is a staunch advocate for the promotion and elevation of naturopathy in Australia, in her role as acting president of the Naturopath and Herbalist Association of Australia. So we love Hannah and we love Lara. So thank you both for sharing your brains with us tonight. We've got some really interesting questions that people have sent in. And obviously, everybody, I'll just let you know if you want to ask questions or there's something that comes to mind during the chat, just feel free to put it in the chat box and we'll hopefully try and get to it before we finish up. So we've got, a few different varied areas that people wanted to cover tonight. So everything from endometriosis, some perimenopause, menopause questions, a couple of thyroid, and then just general hormonal questions that that people want to know the answers to. So this is kind of a mashup, I guess, of Q&A conversation. It's very casual, so I hope you all enjoy it. So maybe let's start, Hannah and Lara, with endometriosis, because such a big topic, and I know quite a lot of people were keen to hear more about it. So I'll just throw out one of the questions that we got on endometriosis, which is, what is the best way I can avoid my endometriosis from growing back? Is there a cure? How can I best manage it without hormonal therapy? I don't know who wants.
That's a big question. I mean, I will just
right in there.
with it. Well, so much that I've learned about endometriosis has come from Lara. So, she's absolutely been such a, she's changed how I see endometriosis as a real immune-based condition rather than just a hormonal one, and that is just so much more part of everyday understanding. So thank you, Lara, for bringing that all to our attention. That's been just a huge part of my practice and helped so many people. That's a great question. How do you stop endometriosis from returning after surgery? Where do you want to start with that?
Let's have a chat about that. And I also want to hear about some of, if you're willing to share some of the work you're doing, Hannah, on kind of group consults around endo, which I think is very interesting. So we can talk about that. And I also just wanted to say, for everyone listening, as you may know, I'm Canadian. I have a Canadian accent, but I'm very connected. I feel very connected to the Australian naturopathic community, even though I don't live in Australia anymore. I think I've become more nostalgic for it, or sort of more connected since I left. So Hannah and I know each other physically. We work together in Sydney. We're fellow sisters, Sydney naturopaths, which is just kind of nice.
I still think of you as a Sydney naturopath, actually, even though you're not quite. So
I know
that's nice.
I still do think of myself as a Sydney naturopath, and the whole Australian naturopathic community has had a huge influence on me. So endo, now we are in a time of flux and change around this condition, which is long overdue. It is I'm trying to think where to start, what the way is, the existing paradigm has been, there's these lesions, of disease that you have to excise or surgically remove and hormonally suppress. And, the official narrative is there's no cure, which I'm willing to, repeat. I don't want to assert there's a cure when that's not really the case. But it's just, there's so much more to it. And there's so many, even in just the last couple of years, I've started to realize there's way more to it than even my work around gut microbiome and leaky gut and immune system. There's also the issue, and there's that pelvic pain. The main thing women really want help with is pain. Usually it's pelvic pain. I mean, I guess sometimes they're having trouble falling pregnant. So that's another part of it. There could be different symptoms, but usually it's about pain. And importantly, there's kind of a disconnect between pain the actual existence of the endometriosis lesions. So I know that's a little kind of destabilizing to think about it when we've just had this narrative that these lesions exist and they cause pain and you cut them out and that's what you do. And there's just so much more to it. And I've been very influenced lately by another amazing Australian gynecologist, Peter Wright. Anyone who wants to check out my Instagram feed, I just shared a recent interview she gave. I haven't actually listened to that interview yet, but I'm very confident it's great because I've talked to her about all of this. I saw her present some of this last year, just really making the point that there can be like quite severe pelvic pain without endometriosis. And likewise, there can be endometriosis lesions present and they don't cause pain and they don't actually mean very much. They may not mean anything. Like just the mere presence of having, especially the superficial lesions, may just be, Peter Wright says, physiological. Like it may just be something the body's in the process of cleaning up, and it's not a disease if it's not causing pain. And so there's, as you get what I'm saying, there's a lot going on. And in the pelvis, there's like nervous system and these chronic pain things that get set up and history of trauma
and persistent pain as well, right? Because
yeah.
persistent pain, if not dealt with properly from any kind of injury, particularly in the pelvic
Yeah.
area, because there's so much nerve involvement, it is literally
Yeah.
just going to be a cascade of ongoing pain and
Yeah.
discomfort for people. I mean, I've had patients that, you know, have had no symptoms of endometriosis and, you know, definitely through the fertility world, trying to find reasons why their pregnancies aren't progressing and have surgery and go, oh, wow, you've got stage 4 endo. And they had no
Yeah.
pain, no symptoms, no anything
Yeah.
of that classic picture that would make people think. But the adverse is true as well, where you see people who have
Yeah.
clear signs of pain and discomfort and those other sort of classic signs of endometriosis. And yeah, they don't have any lesions whatsoever that are visible in surgery or imaging. So I guess the question is really interesting. Like, how do you stop the lesions from coming back? But as you said, Lara, like it's so much more than just the lesions, you know.
The
like
first question is, are the lesions causing the source of pain?
Yeah.
Or not? Because if they're not, then the treatment is not around the lesions, it's something else. But I guess sticking with the lesions for the moment, and I guess assuming, you know, in answer to the question, I guess like assuming the lesions are the source of pain, which, or infertility, as we've said, because that it's an inflammatory disease. So that kind of inflammation in the pelvis can definitely impair fertility. It's not a hormonal condition. As you know, that's one of my key messages. It's not. It's just not. It's affected by hormones for sure, like strongly, but it's not caused by hormone imbalance. It's something else. It's an immune thing. It may, which is not to say there aren't sort of hormonal influences at different stages, but it's primarily, and I guess through my lens, I mean, the evidence, even like 5 or 6 years ago when I lectured at, you know, the endometriosis summit or symposium we had in Sydney, about the role of kind of SIBO and intestinal permeability. And basically it sounds kind of dramatic, but basically like some of the bacterial toxins called LPS, or like some of the entering the pelvis, like exiting from the gut, from inside the intestine into the pelvis. And we know that's happening because women with endo have up to 6 times higher levels of E. coli in their pelvic microbiome. And that is like very upsetting to the immune system. That is definitely part of what's driving the inflammation, at least in part, at least in some cases. And we know clinically treating the gut like can give great relief. And in some of the studies, even one human study, they found that giving antibiotics, basically knocking back those bacteria, can shrink the lesions and improve pain.
Yeah, right.
So we're at a paradigm shift around this disease. Yeah. Like it won't be long till the days of just surgery and hormone suppression is behind us. That's not the future for this disease.
I love it how historically, you know, women's uterus were this kind of like sterile place, you know, of all the places in the body, it was the only place that actually had no bacteria or anything in it. No. And I just think that's so funny, like the way that, you know, it's very relevant to think about how women have been treated medically throughout the years, that, you know, there's this sterile place in the womb, and it's just not true. So it's
there's a microbiome everywhere. Yeah. Yeah.
And it's interesting, you know, some of the really kind of bigger fertility doctors around the world and in Australia doing more of that. So EMA testing, looking at the vaginal microbiome, the uterine microbiome much more closely. And it is the test that's very accessible to most people, which is just really because it's so expensive and time consuming as well. And so there's a whole lot more research to do and come on that as well. So did we answer that question? I don't know.
You did. I just saw a little someone saying, so do you still recommend surgery? Well, I'll just answer that question that just popped in. I saw it popped up for me. Like, well, it's an evolving question. I think, yes, arguably surgery is still an important part of treatment for some women, for sure. I think most people are still saying that, but experts of all types are backing away from like the routine surgery, and certainly the repeated surgeries. Is no one wants to be doing that anymore. And it's just, I predict there's better things. Like I predict maybe it's good that we've had surgery that has helped some women, but a lot of women haven't been helped by it, and there's better options going forward, I think.
I agree. I mean, there's a time and a place for it, I think. So, but not, it doesn't fix it, you know. I think that's really important.
Do you want to say a word about your group consult thing?
Or
not?
I mean, I'll talk about it till I'm, you know, fallen over. I love it so much. And I think shout out to some of the lovely people that might be listening tonight that are in the group. So the group shared consults. So basically we work with it was part of a clinical trial at SCU, and we take people with endometriosis, and we have shared naturopathic consults every month at the moment. It was every fortnight, and look at their aspects of the health. And it's so fascinating because although they're all there for endometriosis, that's the criteria that they must fit to be part of the group, everybody is dealing with different things. You know, we've got a lot of gut stuff, a lot of chronic pain stuff, a lot, you know, a lot of mental health stuff, lots of different things that people need to support. Because what's so interesting about, well, it's so important to manage with chronic conditions is it's not just dealing with the heavy painful periods of endometriosis, it's the impact to their quality of life. And that's where I see naturopathy being so beneficial in helping people manage those things. But it's I love the group work. It's just such a special place. I think everyone gets a lot out of the shared support from it. And it's amazing. Everyone should do it.
Interesting model, kind of treatment model going forward for other conditions too, or potentially.
Well, we're planning a perimenopause one as well, which I think is just, we're going to have a few questions about that. But I do think that in terms of a group of people that have a real disparate, like group of symptoms that are sitting there going, what is happening to me? You know, like, what is this? Is this normal? And, you know, really working out what it is. I think that's going to be a good one. But interestingly, I was a conversation that I had with someone just yesterday about trans men in Sydney with endometriosis. Apparently there's quite a lot of them, and having a group consult for that group of people would be like super fascinating. So there's a really high percentage of trans men with endo, which is amazing. So
how big are the groups usually, would you say? Like,
look, 7 is probably a good number. It actually depends, you know, you could do 4, you could do 5. It just depends who turns up. But I think I did 9 for the initial trial, and that was a lot of people. But I enjoyed it. It was fun. It was it was good. You have a facilitator that helps kind of arrange everything in the background and make sure that everyone's there. But it is definitely a lot to manage, but it's good. It's great.
For sure. Great. Good. All right.
Okay. Next, I'll just kind of keep moving on and just sticking with endometriosis maybe for a tiny bit longer. A couple of people have asked about the naturopathic treatment and how it's best managed from a naturopathic perspective, and even down to things like how to reduce the bloating that so often goes along with endometriosis. And you kind of alluded to that, Lara, when speaking about gut health. But, you know, someone was asking if there's any simple tips on maybe things to do at home even.
Well, I think we won't go into all the details of that today, just because it'd be nice to get some other topics. But I mean, I've written about it in both books in terms of like some simple treatment protocols. Hannah may have some articles about endo as well. And then I have a podcast. I'll maybe put it in the link. I have it's a podcast / YouTube video called Endometriosis is a Disease of Immune Dysfunction. It's about 15 minutes long. And I do talk about some of the natural treatments, including some of the diet changes. I just say, for what it's worth, like the bloating, I just want to emphasize again what the research is suggesting. It's not necessarily that endo is causing digestive symptoms. I mean, it can, but so there's maybe a little bit of that, but it's the other direction. It's an underlying problem with digestive system, like with the gut, is driving endo, not necessarily causing it, but certainly like pushing it or like really inflaming it. And so the gut comes first, like lots of things in naturopathic medicine, but like if you treat the gut, you can to some extent treat endo. So, and that's usually, yeah, diet changes. And I do use a lot of herbal antimicrobials for endo. Are you doing any of that with your group stuff, Hannah? Like, are you actually prescribing like berberine or any of those things? Or
some of them, yeah, some of them have. You know, some of them, yeah, definitely. I mean, I use a lot of berberine for endo at different stages of that. I'm not I don't like using it for too long though, you know.
How long do you use it?
It's always sometimes it's really hard to get people off it because they're like, I feel really good.
I know.
They do feel really good on berberine, but I tend to try and do a bit of a pulsing thing sometimes and get them to not take it every day. There's definitely some new research that I caught up on last year from, you know, or this year, what year? Last year with like the wonderful Jason Horolak, and talking about berberine and the new research on that, saying it is pretty indiscriminate on the gut, and you don't want to use it for too long. But I guess it is looking at the different forms of berberine that are available, and how they're active, not necessarily just in the gut, but if they're more absorbed systemically. When we're looking at the use of berberine for sort of metabolic health and PCOS and stuff as well, there's some other different forms. So I'm a bit cautious of it. But you know, when you get those antimicrobials that actually just make people feel really good, you know that it's because, you know, sometimes they don't need a very high dose. Like a lot of the dosing schedules that you see is actually super high. And most of my chronic patients are pretty depleted and tired, and I'm not going to push it that hard. They don't need a healing crisis in the midst of you know, endometriosis flare or whatever. So, but yeah, I'm cautious.
I tend to give it dose it quite low as well, and pulsing, and maybe do like a few courses, maybe two, like an 8-week course, take a break, an 8-week course, take a break, and then maybe look at probiotics or other things to sort of continue the gut work, if that might give people kind of a sampler of what we're talking about here, gut stuff for endo.
Great. Okay, let's move along to a slightly different area now, and that perimenopause, menopause stage. And we've had a few questions around hormone replacement therapy. Lara, I know on your website is actually a great resource talking about body identical hormones, hormone replacement. Someone's asked what's the best body identical progesterone. And there's also a question about testosterone as a hormone replacement during menopause. And what do you guys think of that?
All right. So first of all, I'll just say a couple words about words, like the terms, because it's sort of interesting because well, one, the modern term, and I do prefer it actually, is hormone therapy or menopausal hormone therapy, because it's not, I mean, using the word replacement, not just you, but I mean, traditionally that was the word, but like it sort of implies that it's a deficiency state that requires replacement, like, you know, how underactive thyroid requires replacement thyroid hormone, or you know, it's not analogous to that. So I think that's important. But that said, as you know, in my book, I'm in favor of hormone therapy if women need it, for sure. Like, I think some women don't need it, but some women do. So I take quite a you know, even line through that, acknowledging the benefits and also acknowledging that some women don't need it. But also the term bioidentical. So I kind of don't use it anymore. I'll tell you briefly. I also have a podcast about this called A Safer Form of Hormone Therapy. I'll just say that it's just to give a super quick, like 2-sentence history lesson. I mean, bioidentical just means hormones, usually estrogen and progesterone, that are identical, like molecularly identical to human hormones, which are safer. I mean, that was sort of intuitive. I think a lot of us thought that 30 years ago when I started practicing, but it was not proven. It was proven kind of more in the last 10 years that it's safer for, especially using real progesterone rather than progestins, is safer for breasts. That's a big part of why so-called bioidentical or body identical progesterone in particular has become mainstream. Like in Australia, it was 2016. I remember the moment, I remember where I was sitting. I remember my first patient who was prescribed and, got kind of mainstream body identical hormones. And we're like, we said to each other, she's like, let's just take a moment. I'm like, yeah, this is so that, like, so in Australia, it's called bioidentical progesterone, body identical progesterone, it's called prometrium. And it's this kind of standard prescription now for menopausal hormone therapy because it's safer. But there's still this, because up until 2016, Australia, the only way to get these safer hormones was via a compounding pharmacist. So it was all, and I'm not saying still, I in defense of compounding pharmacists, there's still sometimes reasons to maybe get it through them. So I'm not saying never, don't use a compounding pharmacist. I'm just saying that's not the only way to get it anymore. Like it's now mainstream. And yet a lot of doctors, depending on the doctor, like some experts just have this kind of knee-jerk negative reaction to the word bioidentical. And it's just because of that history of how it used to be kind of the alternative that you had to get from compounding pharmacists, and they didn't like that. So I generally, in my books, I don't say the word, depending on the doctor, don't say the word bioidentical because they don't like that word possibly. Just say, can I have Estradiol? That's the main natural estrogen with a brand of it, and Prometrium. Like, just ask for it by brand name because it's just so much easier.
Absolutely.
You don't have to they don't have to get worried that it's some kind of natural thing. It's just the standard hormone therapy these days.
And you do see that. I'm seeing that definitely with patients who are being prescribed HRT, and they'll say, I'm on HRT on their, medication intake form. And then you speak to them and actually they're on Prometrium and estrogen. And it's really, I find the education for doctors they need to step up a little bit. And this is, and it's a challenge to them. They're probably not going to be listening, so that's fine. But I do think when they tell our patients, just take the estrogen progesterone every day, you'll be fine, they're missing the whole point. Because some menopausal women do really well with a bit of both every day. But most women, as we know, they have very fluctuating hormones that are different from the next person. There's no individual box we can put ourselves in. So I find that women learning how to dose themselves with the prometrium and estrogen, they're not getting a lot of good guidance from people sometimes for that. I don't know if that's something that you see.
Well, it's interesting actually, because as I explained in Hormone Repair Manual, I'm sort of in the camp, very influenced by the endocrinology professor Geraldine Pryor, who helped me with my books. In perimenopause, when you're still having periods, you don't need the estrogen part. You're actually making up to 3 times more estrogen than you were before. So at that point, if anything, there's lots of natural things you can do, but if anything, you need the prometrium part, the progesterone part. And at that stage in a woman's life, when she's still having pretty regular cycles, it makes most sense to just take it luteal phase, like the 2 weeks when you normally make progesterone. That's unless there's a reason to take it daily. So it is true that in a woman who's still cycling in perimenopause, if she takes a big dose of progesterone daily, she'll get weird. Her periods will go all weird from that. It suppresses ovulation basically.
If she takes it daily every morning, she'll just be sleepy all day long.
And never take progesterone in the morning. I just
I've had patients are like, why am I so tired now?
No.
And it's happened 3 or 4 times. The doctor's like, just take this, and no instruction about when or the best time to take it.
Pharmacists should be telling them take it at bedtime.
Yeah.
It's so tranquilizing. Some women, it just knocks them out, which, to be fair, in perimenopause, that can be quite nice actually, to be knocked out like a sleeping pill with, there's other ways to sleep apart from progesterone, but it
does help with that perimenopausal
It is very
sleep
inducing usually, and it's not addictive. So obviously it's better than sleeping pills that you could use for that.
And there's always herbs for that, Lara. Don't forget.
Yes, and there are herbs. There are lots of herbal medicines, and herbal medicine is awesome for perimenopause. Actually, there's lots of things you can do. Yeah.
And what do you think about testosterone, you guys, in that perimenopause or menopausal phase? Is it something that you would steer a bit more clear of?
Okay, well, just one thing just to know, piece of information. There's a sweet spot with testosterone, and too much testosterone causes weight gain. That is 100% categorically true. So this is what happens in PCOS. This is what can happen with higher dose testosterone. So you just need to be careful. I think a lot of women are using it for libido, which is valid. It does work on that. That's the one thing it does actually work on, is potentially. But that said, not everyone gets a lower libido with menopause. That's a myth, actually. There's quite a bit of variability in that. So it somewhat depends on relationship status, which is pretty logical. Really,
home life duties as well as another big one we see from women.
There's exhaustion, getting enough, whether you're getting enough sleep. There's so many factors.
Yeah.
So many factors in libido. So in answer to the question about testosterone, just from a hormonal perspective, it's quite interesting actually, because as I describe in Hormone Repair Manual, we do, interestingly, in perimenopause, we do get a slight, ever so subtle kind of what I call testosterone dominance in going into menopause. Our testosterone is not going up. It does actually go up a tiny bit, but it's usually testosterone is just on a linear way down. Like it's not going over the cliff like estrogen and progesterone. It's just from teenage years till old age. It's just sliding down in both women and men. It's doing the same thing. It's just kind of going down, down, down. So it, arguably from that perspective, it's not something you should routinely need to like replace or take. But where we get the relative testosterone dominance is actually because both estrogen, estradiol, our main estrogen, and progesterone have an anti-testosterone effect. So when we're cycling and making lots of those hormones, it's kind of pushing down on testosterone essentially, or sort of buffering the body from its effect. And then when those hormones are less, that they don't go away, estrogen doesn't go away entirely, but when it's less, then you do, via several mechanisms, get more testosterone coming through, which makes sense, right? Because that's why you get more facial hair in perimenopause. Like some women get breakouts. So these are testosterone symptoms and weight gain. In part, I think the perimenopausal gaining of visceral fat and weight gain around the middle is partly from testosterone. So that's why I would be very careful taking it. And if you do take it with in that case, you would definitely always take it with estrogen and progesterone as well. And from a libido perspective, I will tell you, I just heard from my colleagues that it's been available in Europe for a while. It's just been approved in both Canada and the US, vaginal DHEA.
Oh, wow.
DHEA ever on your radar? So back when I started practicing as a naturopathic doctor back in the 90s, like we could prescribe DHEA. It was like, I thought it was going to be the next thing for menopausal women, but it kind of got pushed to the side. It didn't really get clinically trialed very much at all. But now it's been approved for topical use, and it's good for like dryness and also for libido. So there's another option there.
Yeah, I think I've seen people being prescribed testosterone for energy, like if they're tired, and it's we have to be careful with these hormones, I think, without looking at the holistically. Like I think as naturopaths, that's what we're very good at doing, is going, okay, you're tired, or you're cranky, or you've got sleep problems. Like, is it your hormones that are causing that, or is it other things we need to address that's going on?
Because testosterone is a mood enhancer. So it's kind of a quirky thing about it, actually. It is probably going to have a mood enhancing effect, especially when you first start taking it. But yeah, as to what that's, big picture, it just depends on the dose a lot. So, and that's a longer answer. There's a bit of discussion right now, debate about testosterone and how, whether it's safe for breasts, for example, but a debate around that. So
there we go.
Jury's still out.
Yeah.
All right. Okay, let's keep moving right along. Got a question to do with the thyroid and Hashimoto's. Does Hashimoto's affect breastfeeding, and how can you limit Hashimoto's symptoms postpartum?
Yeah. Well, I'm happy to have Hannah. I mean, there can definitely be a flare of autoimmune thyroid postpartum. It's quite a common time for it to flare up. Hannah, did you want to chime in with one? So talk a bit about postpartum thyroid. Yep.
I guess it's always on my radar, you know, particularly,
Yeah.
you know, as you said, it's a time when thyroids can go crazy and women sit there 9 months postpartum and go, well, oh, I'm just tired because I've got too much going on. You know,
Yeah.
surely that's what's going on. I just sleep deprived. But, you know, so many times I see simmering antibodies in their pathology. It's quite shocking how often I see it, actually. And I know thyroid conditions, particularly autoimmune thyroid conditions, are so complicated when it comes to the triggering of them, but the adrenal health is just, for postpartum, is just the most important thing that we can focus on. You know, it's not as simple as saying, you know, look after yourself so you can look after everyone else, but it kind of is in a way, you know. And I think that that has a huge impact on thyroid. You know, during pregnancy, that whole immune suppression thing kind of keeps everything in check. But when you see hormones changing and stress changing suddenly when you're breastfeeding or stop breastfeeding, or, you know, you're recovering postpartum, that is a time when you see flares of so many things going on. So how do you can, I don't see why there'd be no reason why a well-managed Hashi should not be able to breastfeed at all. I've never seen that be an issue in my clinical practice. Breastfeeding is complicated anyway, you know, so there's lots of other reasons that it might need support. But in terms of managing Hashi flares afterwards, well, rest and good care help goes a long way, I think. And nutrient status.
There's some things you can give safely in breastfeeding. You could give a little bit of selenium, which is good for Hashimoto's. Probiotics, you know, there's some things you can support, and, you know, some support for, as you say, kind of for the nervous system side of things, like some magnesium. I always have to mention magnesium. You know, so
what doesn't it do?
So glycine, so, you know, maybe a B complex, which might be in the breastfeeding multivitamin anyway. But the other things. And would you give? I am a pretty big fan of withania. Do you give ashwagandha kind of withania? Postpartum. Yeah.
I do. I mean, I definitely do. I'm cautious
Yeah.
of where it is everywhere. It's not a herb for everyone. I am cautious with Hashimoto's, particularly if they're on thyroxine. So that's the one thing that I think is really important, because it can have a really triggering effect. So when you see a lot of these postpartum formulas that are just given to women without checking, you're just tired, so you need ashwagandha or withania. That's the answer to everything. Well, if it's thyroid, then it might actually not be the best thing for that. So always check.
Right. So you feel like that could interfere with thyroid medication? Is that what you're saying?
Yeah.
I'm actually just curious. Yeah. Okay.
Yeah. I'm cautious just because, you know, particularly postpartum, when everything's, you know, women are coming out of 9 months of pregnancy. That's a natural depleted nutritional state. If they are breastfeeding, if they choose to, then that's another, you know, trigger for their deficiency state as well. It needs to be well maintained. So making sure that there's all those other, you know, zinc for the thyroid, you know, as you say, selenium and iodine, you know, needs to be checked for thyroid conditions. Like, you can't, you know, women are taking lots of iodine, and that's another thing for the thyroid that you just have to watch so carefully, because if they don't need it, my God, you don't want to spend them, you know, 2 years on prenatal Maltese taking too much iodine as well.
True. You have to be careful with iodine. That's for sure.
Yeah.
Right.
Okay. And so now we've got, I guess, some just more general hormone health questions that I'll just kind of throw out there. And one of them is, why does it take so long to heal hormonal imbalances?
Not that it always does. I mean, I guess it depends honestly, it sort of depends what it is. Like using PCOS as an example. We haven't talked much about PCOS, but it's very common. That could take a while. Again, depending on, I guess, how severe the hyperandrogen, like the high testosterone is, and how severe insulin resistance is. That can take, you know, 6-12 months to kind of reestablish really robust, kind of good natural menstrual cycles, and like reduce, like facial hair, for example, takes ages to. There's just this, like, with certain things, there's a lag time. Like, so even once your hormones are perfect, if you've had excess testosterone stimulation of facial hair, that could take 12 months just for the symptom, like for the hairs to, like, you know, change, and they're never probably going to go away once that's become established. That's an example of something that could take a long time. Recovering from hypothalamic amenorrhea, like losing your period to undereating, can take minimum probably 3 or 4 months, but usually within 6 months you can usually get your period going. Premenstrual mood symptoms can improve within days.
And
like,
someone has asked about that, specifically
yeah,
premenstrual dysphoric
I mean,
disorder,
that's
which
a
is
very rapid,
different.
that's a
But
lot about neurotransmitters, I think. So you can get relief from that within hours or days sometimes. So that's not a slow building thing, like, removing or, dealing with facial hair might be. I'm just, what are your thoughts, Hannah? Some other examples of, hormonal conditions and time frame and yeah.
I think when we're looking at that autoimmune picture, it can feel like a long time for people, because obviously, I mean, I always say to my patients, if you're turning up in the naturopathic clinic, you already are doing enough for your health. You already like know enough about wellness. So when you don't feel well, it feels even more frustrating, because you're like, I'm already doing all these things. Like, why aren't I getting better, or why don't I feel better? But I guess when you're looking at that autoimmune stuff, it is complicated. And I guess for hormonal stuff, because women have these cycles, it dictates the time of change sometimes when you're looking cycle for cycle. And I always say to my patients something, that you said to me a long time ago, Lara, you just need patience, particularly with things like PCOS and amenorrhea. You have to have patience. Your doctor will offer you the pill to fix the problem, and we know that's not fixing the problem, but patience and time will make a huge difference. So
one thing that might help people to understand this is what I talk about in my book, the 100 days to ovulation. Like we think about, so a lot of menstrual health and estrogen, everything to do with estrogen and progesterone is to do with, the ovarian follicles, basically the eggs in the ovary, maturing, becoming, active, becoming dominant eventually. And like, it's only one egg that comes to maturity and then makes progesterone. That's how you get your progesterone, from one egg that took 100 days to get there. Whereas, estrogen is coming from a few of them. But just to put that in perspective, so each follicle, it's not like it just springs into life out of nowhere. Like the ovarian follicles take 100 days to develop, like it's slow, like they're tiny, and then they're just like slowly going. So this is why, regaining your period, after losing it to undereating, for example, you have to expect to give a 3 or 4 month lag time, because stuff has to happen. Like the follicles have to start being stimulated to grow.
Yeah.
So,
and that's 100 days really, if you're looking at a kind of per menstrual cycle, right? So if someone's menstrual cycle is coming in at 50 days because they're recovering from hypothalamic amenorrhea or something, then it's going to take even longer for those ovaries to kind of go, I'm still working here. I'm just working at a slower pace. I mean, once it starts, it's kind of, to get to that ovulation every month, sometimes it's just taking women longer and longer because of external factors to that as well.
Well, a lot of the follicles never make it to ovulation. That's part of it. But each individual follicle only takes 100 days, but most of them don't get there. And so it depends on how many have been recruited. And I mean, and also just to say, just for I mean, this, I always like to try to insert this piece of information. A menstrual cycle does not have to be 28 days. It absolutely does not. I've had people say to me, oh my, what can I do about my irregular cycles? And then I find out her cycles are like 27 to 31 days or something. I'm like, that's fine. Like that is totally fine. Like that's not an irregular cycle. An irregular cycle is kind of what you described, like maybe 3 periods a year, or maybe bleeding every 10 days, and then bleeding for 10 days. Like, that's so. By definition, what a menstrual cycle needs to be is an ovulatory cycle where ovulation occurred. And if that's going to happen, it will typically be anywhere from sort of, bleed coming every 21 days, and that would be more like in perimenopause situation, quite close together periods, and that's still normal for a woman in her 40s, up to every 35 days, even every 45 days for a teenager. That's normal. That's good, especially if, at least some of them are ovulatory. A teenager's not going to ovulate every cycle. No way. That they're like, the body's just learning how to do that. It's just kind of practicing. It's like training wheels. It's like getting ready.
And also, if we know anything about what they like to say about women, is they like to put us in boxes and make us all the same, right? So making sure that every woman has a 28-day cycle, because if we're not perfect 28 days, then surely something must be wrong with us, right?
Well, and also the other thing to say about this point, which I'm sure everyone listening to us already knows this, but pill bleeds are not periods. So there's no medical reason to have a monthly bleed on the combined pill. you can take the combined contraceptive, if you need it for symptoms or whatever, or preventing pregnancy, but you don't have to bleed monthly on it, because that makes no sense.
Ah, yes. The little box that we're all meant to fit into. It's got a lot to answer for.
Yeah.
Yeah. Okay, we're kind of coming up to, wrapping it up.
Yeah.
Maybe we'll just have one more question about treatment with herbs and dietary kind of interventions. Someone's asked, should we take supportive herbs as a long-term regular practice, or should we only use them to treat symptoms when they appear? And should we be taking herbs and certain foods the whole month, or only at some points in our cycle, say in the follicular phase or the luteal phase? What do you guys think about bringing things in and out at different times during the cycle?
Okay, I'm gonna jump in here because I can hear like seed cycling coming in the back here, and I'm definitely a huge advocate of trying to make life easy for my patients, not more difficult. So I think if I can get women eating flaxseed, maybe a few times a week, then we're like winning, for that treatment. If I'm telling them you need to eat 2 tablespoons of that every day with sesame seeds and walnuts, for 2 weeks of the month, and then the other 2 weeks of the month, you've got to do something else, someone's glazing off and they're like, that's too hard. It's a very, very certain type of person who can be strict with those things. And so I think in terms of food, if it's good, eat it, be balanced, be kind to yourself with it. Like there's no you need to not treat food as anything other than fuel, and just understand how it's helping you. I'm a huge one for thinking about that. I think in terms of herbs, I am a herbalist, so I will say herbs for life all the time. But do we need the same herbs all the time? No, I don't think we do. I think that definitely changes what we need. And, the availability of herbs is so common these days. You can get them from Coles and Woolies, which, just kind of shocks me sometimes, because they're potent and they work. We also really need to be mindful of the environmental impact of herbs as well, like using them correctly and dosing them well, so we're not, using too many, and being really mindful about the ethical nature of farming practices as well. So yes, herbs for life, but, obviously taking all of that into consideration. That's how I think.
There's lots of, it depends on the herb, right? It depends what it is. Like, I'm just thinking of an easy example, which would be herbal medicine, technically, which would be like dandelion root. I know that's very old school, but like
good herb.
That could be a thing that you have as a beverage, like daily, like, that's a thing. That's a herbal medicine. I'm agree with you. I think it depends on the sustainability of some extent. I mean, I personally do take a lot of herbs, just kind of day to day. I do. I mean, if I'm just thinking about what I'm just like, yeah.
What do I need today?
Yeah, I take stuff. I think once you become a herbalist, once you just want it, you just want that extra support. So
I understand it's not for everybody, but I do think herbs are for everybody. I think it's really important for people to have that taste of bitterness, to understand what things are. We have so much sweet in our lives. I mean, I was given Chinese herbs when I was 6. So, I'm like used to it. So I think if I can do it at 6, I did complain about it a lot. Don't worry. I think we can all do a little bit of herbs every day.
So in my newsletter that's coming out tomorrow, actually, I just wrote it. I'm going to send it out tomorrow. It's a link to a study about how humans evolved with herbal medicine, like pretty much, and that across cultures, like people use. And they were using them to some extent, they think, for their antimicrobial properties, just because our food supply used to have. I mean, we were just exposed to things. I mean, there's bugs in the food we eat. That's just a fact. So like spices are herbs, technically, like turmeric, and that's arguably herbal medicine. So it's an interesting question. I think it, in terms of like, if you're taking something for periods, how long do you take it? It depends on what the medicine is. I get a lot of questions about Vitex. I might answer that, because that could be partly what people are thinking when they ask that question. I guess what I would say, and I'm curious to hear, Hannah, your thoughts, but my experience with Vitex, and you can tell me whether you agree, I feel like it can be very potent in terms of promoting ovulation and helping with premenstrual mood symptoms as well. And I do feel like the results of it kind of attenuate over time. So with my patients, I've been like, after you've been on it for like 9 or 10 months, and if it's, even if it's been working, like maybe just do a little reset, take a break, do something else for a while, and then come back to it. I don't know. What are your thoughts about Vitex and how do you dose it?
Yeah, look, I have some patients who just will take it every day forever, because when they stop, it's not a problem. And then I have some patients that in their medical alert at the top of their file, I say no Vitex ever,
Oh, right,
because some women just absolutely have a horrendous, because it is so potent on the period, it can really impact things, particularly women with PMDD. I find that that's actually the worst herb that you can give women sometimes, not all the time, but yeah, sometimes you say it's 3 months of Vitex can actually just like make a huge impact on people's cycles, but it's not the herb for everybody. I don't think it's not the panacea for all women's
no, it's not
stuff.
Do you mind saying on, or you tell me if you don't want to, but I'm just curious what brand you use or what kind of dosing, because it's very dose dependent herb, isn't it? Like I actually think if you go too high with the dose, you're not going to get any benefits.
I use all forms depending on the patient. This is like so it really depends. I'll use tinctures, and then I can modify the dose depending on what I think the patient needs, because obviously looking at the use of herbal medicines, liquid tinctures, you can kind of dose differently. I use the really low dose one that's been around forever, and I do use some other ones that are a bit higher dose, but it really just depends on the patient and what the outcome is that I'm taking. So sometimes for fertility stuff I'll go higher, sometimes for PMS stuff I'll go a bit lower. Like just really depends. I read the patient. The patient tells me what that sounds so weird and hippie, but it's not. I'm sure you know what I mean. Like when you look at a person, you're like, you don't need much herbs to make effect. Like not everyone needs heroic dosing of herbs to make a difference. I mean, herbs are there to restore balance in the body, not to like push change strongly. You know, that we want the herbs to be used in a way that goes, there's balance. You know, when you look at digestive herbs and mood herbs, you know, they don't fix the anxiety. They support the body to go, I can deal with this anxiety, you know. So I think things like hormonal herbs can work that way. They can work fast or strong. Yeah. Get into the energetics.
It's nice to speak herbal medicine, actually. It's a little bit more old school naturopathy, right? Like just
love it.
Yeah. We get so lost in all the other stuff, like the supplements and the microbiome and everything, and herbal medicine. And just on the topic, I mean, we'll finish up soon, but just sharing with you, like, so as you know, I'm just kind of chatting, but like I trained in Canada. We use drop doses. So then I came to Australia. I'm like, what the heck? Like, what are these like milliliter doses? Like, what is happening? And so I had to really kind of get my head around that. But now I do prescribe them like that. Like I sort of like I learned the Australian system, which I guess is the British system. I'm just using these, bigger doses sometimes.
I have patients that I'll drop dose with, and
still drop dose.
Look, if that, because you'll know if it doesn't work as well, or it works, they have an adverse reaction. And sometimes, particularly with hormonal stuff, I have a few patients that if you give them more than just a little bit, everything will flare, but a little bit does so much. So it's just that encouragement to actually make sure that you read the patient, you know, like, and that's what I think about self-prescribing. Sometimes you're not sure where to go, but just have a chat to someone, particularly with herbs. They're so awesome.
Yeah, and so beautifully customizable to the person in front of you, so individualized.
Nice.
I think we've pretty much run out of time, so we'll have to leave it there. And I apologize to anyone whose questions we didn't manage to get to, but thank you so much, Lara and Hannah, for spending your time with us tonight. It's been really enlightening and a really fun chat. Covered lots of different topics. So thank you so much on International Women's Day.
Yes.
And we'll try and make the recording available too, I think, won't we, Hannah? So
we'll get that out to everybody. So yes, thank you, everybody. What a great chat. Thank you, Lara.
Thanks,
I just love chatting to you. So it's nice that we can do it.
Felt like one of many chats that we've had on Zoom, except that we recorded it.
Had an audience.
It's good everyone listen to how we chat most of the time. So welcome to the
this is what we're
naturopath
like. Yeah.
bubble world. So it's all good. Well, thank you everyone. And
Okay.
yeah, we'll get in touch if you got more questions, and we'll see you soon. Okay.
All right.
Thank
Bye,
Take care,
everyone.
Hannah.
you.
Thanks. Bye.
Bye.